Anastomosis. An anastomosis is a surgical connection between two structures. It usually means a connection that is created between tubular structures, such as blood vessels or loops of intestine. For example, when part of an intestine is surgically removed, the two remaining ends are sewn or stapled together, anastomosed. Extrahepatic bile ducts. Extrahepatic bile ducts are small tubes that carry bile outside of the liver. They are made up of the common hepatic duct, hilum region, and the common bile duct, distal region. Bile is made in the liver and flows through the common hepatic duct and the cystic duct to the gallbladder, where it is stored. Intrahepatic bile ducts. Intrahepatic bile ducts are a network of small tubes that carry bile inside the liver. The smallest ducts, called ductules, come together to form the right hepatic bile duct and the left hepatic bile duct, which drain bile from the liver. Bile is stored in the gallbladder and is released when food is being digested. Anastomosis, hepatic biliary ducts and GL tract. The physician performs an anastomosis between an hepatic biliary duct and the small bowel. The physician makes an abdominal incision and explores the abdomen. The extra or intrahepatic biliary duct is divided and anastomosis is formed between an extra or intrahepatic biliary duct and the small bowel with sutures or staples, end to side. The incision is closed in layers. Anastomosis, of extrahepatic biliary ducts and gastrointestinal tract. Anastomosis, of intrahepatic ducts and gastrointestinal tract. Anastomosis, Roux-en-Y, of extrahepatic biliary ducts and gastrointestinal tract. The physician performs an anastomosis between a limb of small bowel, Roux-en-Y, and the gallbladder and stomach. The physician makes an abdominal incision and explores the abdomen. The proximal small bowel is divided and anastomoses are formed between the distal limb of jejunum and the gallbladder and the stomach with sutures or staples. The proximal end of bowel is approximated to the limb of jejunum distal to the gallbladder and stomach anastomoses. This procedure is usually performed for a mass obstructing the bile duct and stomach. The incision is closed. Anastomosis, Roux-en-Y, of intrahepatic biliary ducts and gastrointestinal tract. The physician performs an anastomosis between a limb of small bowel, Roux-en-Y, and the intrahepatic biliary ducts. The physician makes an abdominal incision. The bile duct is isolated and dissection is carried proximally along the duct into the liver parenchyma, exposing the intrahepatic biliary ducts. The bile duct is divided or excised. The proximal small bowel is divided and an anastomosis is created between the distal limb of jejunum and the intrahepatic biliary ducts with sutures. The distal bile duct is oversewn. The proximal end of bowel is approximated to the limb of jejunum distal to the bile duct anastomosis. The incision is closed. Internal anastomosis of pancreatic cyst to gastrointestinal tract, direct. The physician creates an internal anastomosis of a pancreatic cyst to a portion of the gastrointestinal tract. The physician approaches the pancreas through a midline abdominal incision and retracts the skin and underlying tissues laterally. The physician approaches the pancreas through the lesser sac of the omental bursa or through the transverse mesocolon. The cyst is located. The physician approximates the stomach wall or a loop of duodenum or jejunum and incises it. The anterior cyst wall is incised and the cyst edges are approximated with the cut edges of the gastrointestinal tract and sutured. The cyst is decompressed through the drainage tract. The surrounding tissues are returned to anatomic position and the operative site is sutured in layers. Internal anastomosis of pancreatic cyst to gastrointestinal tract, Roux-en-Y. The physician creates a Roux-en-Y anastomosis to drain enzymes from the pancreatic duct. The physician approaches the pancreas through a midline abdominal incision and retracts the skin and underlying tissues laterally. The physician approaches the pancreas through the lesser sac of the omental bursa or through the transverse mesocolon. The physician divides a loop of small intestine, usually the jejunum, and implants the distal end into the stomach or duodenum. The proximal end is anastomosed distal to the first anastomosis to prevent reflux. The pancreatic duct is fistulized to the proximal end to create a drain to the gastrointestinal tract for pancreatic enzymes. The surrounding tissues are returned to anatomic position and the operative site is sutured in layers. Venous anastomosis. Venous anastomosis is a surgical connection between two veins. Venous anastomosis, open, portocaval. The physician performs portocaval venous anastomosis. The physician places a long right thoraco-abdominal incision and exposes the liver. The physician exposes the inferior vena cava and portal vein through careful dissection. The physician places a plastic sling around the portal vein and ties it closed, just proximal to its bifurcation. The physician clamps and divides the portal vein. The physician applies a partial exclusion vascular clamp to the front of the vena cava and removes a small oval of tissue from the vena cava to allow end-to-side anastomosis of portal vein to the inferior vena cava. The physician removes the clamps and checks for appropriate flow without anastomotic leakage. The physician closes the incision, leaving a chest tube in place, but no abdominal drains, as this may lead to protein loss from postoperative drainage of ascites. Venous anastomosis, open, renoportal. The physician performs an abdominal incision and exposes the left renal vein and inferior vena cava. The physician transects the left renal vein and attaches it to the portal circulation by sewing the vena caval end to the portal vein, the superior mesenteric vein, or the splenic vein. Alternatively, the physician may divide the portal vein and attach its splanchnic end to the end of the transect renal vein. The physician assesses patency of the anastomosis and may measure venous pressures before closing the abdomen. Venous anastomosis, open, caval mesenteric. The physician performs an upper midline vertical abdominal incision and retracts the transverse colon in a cephalad direction. The physician exposes the anterior surface of the inferior vena cava and frees the posterior surface of the superior mesenteric vein after careful dissection through the root of the transverse mesocolon. The physician isolates a long segment of the superior mesenteric vein with ties and partially occludes the inferior vena cava. The physician removes an ellipse of tissue from the inferior vena cava and performs an end-to-side anastomosis of Dacron graft to the inferior vena cava. The physician occludes the superior mesenteric vein, cuts an ellipse from its anterior surface, and sews the end of the Dacron graft to the side of the superior mesenteric vein. The physician assesses patency of the anastomosis and may measure venous pressures before closing the abdomen. Venous anastomosis, open, sphenorenal, proximal. Sphenorenal, distal, selective decompression of esophagogastric varices, any technique. The physician performs a bilateral subcostal incision from the right midrectus position extending into the left flank, and dissects past bowel and pancreas to expose the splenic vein. The physician dissects the splenic vein free, ligating or clipping any vessels in continuity to the vein. The physician exposes the left renal vein by dissecting through the posterior parietal peritoneum. The physician exposes the left renal vein, partially clamps it, and excises an ellipse of renal vein at its upper border. The physician performs an end-to-side anastomosis of the splenic vein to the renal vein, using harvested vein graft material if extension is required. The physician removes the clamps and divides the coronary, right gastric, vein, left gastric vein, and gastroepiploic veins. The physician may measure superior mesenteric, portal, renal, and splenic venous pressures. The physician may perform venography to establish patency of the graft. The physician closes the abdominal wound. Sophenopolitial vein anastomosis. The physician makes an incision in the skin overlying the side of the greater saphenous vein just below the knee. The vein is isolated and dissected from adjacent critical structures. The physician affixes vessel clamps above and below the incision site. The dissected section of saphenous vein is connected to the popliteal vein in an end-to-side anastomosis. The other end of the saphenous vein is closed with sutures. Once the saphenous vein and the popliteal vein are connected, the clamps are removed and the skin incision is repaired with layered closure. Arteriovenous anastomosis, open, by upper arm cephalic vein transposition. Arteriovenous connection is made in the upper arm by anastomosing the cephalic vein to the brachial artery. Arteriovenous anastomosis, open, by upper arm basilic vein transposition. The surgeon dissects down to the basilic vein on the medial side of the upper arm and mobilizes the vein. A subcutaneous tunnel on the anterior side of the arm is created, and the mobilized basilic vein is transposed to this tunnel and anastomosed to the brachial artery. Arteriovenous anastomosis, open, by forearm vein transposition. The physician dissects down to the vein and artery. The subfascial plane is identified and elevated laterally to the flexor carpi radialis, FCR, and medially to the brachioradialis, BR. The plane between the BR and FCR is dissected and the perforating vessels are identified and cauterized. The pedicle is followed to the antecubital fossa. The tourniquet is released, and the vessels are further cleaned of their adventitia under loop visualization. Using microvascular techniques, a suture for the arterial anastomosis is performed and closure is completed. Suction drains are placed in the neck. If a Doppler is to be used for postoperative assessment, a suture is placed to mark the pedicle site. A splint is fabricated and secured to the arm with an elastic bandage. Arteriovenous anastomosis, open, direct, any site, e.g. Seminotype. Through an incision in the non-dominant wrist or antecubital fossa, the physician isolates a desired section of artery and neighboring vein. Vessel clamps are placed on the vein and adjacent artery. The vein is dissected free, divided, and the downstream portion of the vein is sutured to an opening created in the adjacent artery, usually in an end-to-side fashion, allowing blood to flow both down the artery and into the vein. Large branches of the vein may be tied off to cause flow down a single vein. The skin incision is repaired with a layered closure. This arteriovenous anastomosis will allow an increased blood flow through the vein, usually for hemodialysis. Creation of arteriovenous fistula by other than direct arteriovenous anastomosis, autogenous graft. Non-autogenous graft, e.g., biological collagen, thermoplastic graft. The physician creates an arteriovenous fistula by other than direct anastomosis. The physician makes an incision in the skin over an artery and vein, and the vein and artery are dissected free. A vessel clamp is affixed to each. A length of harvested vein from the patient is used for an autogenous graft Indiana 36825 and is sutured to the incised artery and vein, usually in an end-to-side fashion. The graft is passed in a superficial subcutaneous tunnel that is created bluntly and connects the arterial and venous sites. The clamps are removed, allowing the blood to flow through the graft, creating an arteriovenous fistula. The skin incision is repaired with a layered closure. Report 36830 if a non-autogenous graft, such as biological collagen or a thermoplastic graft, is used. Anastomosis of pulmonary artery to aorta, Damascus-Stansel procedure. The heart is exposed by dividing the breastbone longitudinally. Mechanical, extracorporeal circulation is established and the heart is stopped, cardiopulmonary bypass. The pulmonary artery is cut just before it divides into right and left branches. The pulmonary artery end is connected to the side of the ascending aorta. A piece of Dacron graft is used to construct this connection. This allows the single ventricle to pump blood to the body.